Great. So thank you so much. And correct, I'm here with Veena, but I'm also here with Leslie Howie, who is our operational program manager, who has Connect for Care under her portfolio. So she's not going to be presenting with us, but she's also here to answer any questions from an operational lens, because I'm a manager of quality and I avoid all operational decisions. I come up with the grand ideas and Leslie the privilege of actually trying to implement them within her budget. So anyway, we're really excited to spend a little bit of this, morning for us, afternoon for some of you, telling you a little bit about our Connect for Care service. So the three of us are actually situated at Sunny Hill Health Centre, which is the Child Development and Rehabilitation Program of BC Children's Hospital. We are under BC Children's Hospital, but located about 20 minutes away from that campus. On campus over there is also Child and Youth Mental Health, which also sits in a separate building. So you can see within the pictures that I have on the screen that we are physically three separate buildings, Sunny Hill physically on a different site, but all under the management of BC Children's Hospital. So about 4 years ago, a group of physicians and operational leaders from all three areas came together to talk about service delivery, but more importantly, to talk about how they thought service could be improved, particularly service to kids that they felt were maybe falling through the cracks, that were accessing services at all three of our sites. And because of our lack of collaboration or connection or supported transitions, they were perhaps experiencing suboptimal care delivery. So at about the same time, there was a call from the Institute for the Canadian Foundation, for Healthcare Improvement to become involved with an Institute for Healthcare Improvement IHI Triple Aim project called Better Health and Lower Costs for Patients with Complex Needs. We were successful in receiving a grant from the foundation to participate in this collaborative, and that really launched the work that we were going to be doing, and that helped with the design of the Connect for Care program. So we pulled a team together to participate in this collaborative, and using then the IHI iterative co-design methodology, they guided us through the development of our model, again with the emphasis being that we were really looking at the kids that had the most complexity that were being seen by all three of our organizations, and that's typically the top 1 to 3% of the population served within our health centers, but they're also the ones that are disproportionately high utilizers of health services. So I'm just going to briefly touch on the design method that we used. On the slide previous to that, I did have a website posted where you can access because it's now free source in terms of the methodology. You can go on and they have a handbook that helps you walk through the process. But what we did in terms of designing it was pretty much a very different, or a shift in model of care development. Instead of predetermining and then implementing our care model, we spent a considerable amount of time trying to hone in on our population of focus, really understanding the needs of that population, trying to determine ways that we would be able to identify them in the organization, and then co-designing that service based upon the needs and goals that the families identified, and as well as the care teams involved with them. When we spent time talking to families as well as talking to staff, they told similar stories. They identified that they were really receiving siloed care, that our lack of collaboration and coordination often resulted in significant stress for them, that we had really long waits, that at times children were referred to one service, they had to wait to be seen at that service, only to then be referred to another service, wait again to be seen. to be referred to the third service. And all of that could take upwards of 3 years sometimes to receive a diagnosis. So that really led to that other gap that I've identified on the slide around delayed diagnosis, which in turn means delayed intervention for them, and that we had really lack of standardization, and that our lack of coordination and collaboration was in fact at times giving the families conflicting information. So the family would get something from say the mental health program, and then would have an assessment here at Sunny Hill in child development, and the recommendations that we were giving were not congruent with one another. And so we would pass on that incongruency to the family, and that was causing stress as well, and was creating barriers for the child and for the family to function and participate successfully within their home and community setting. To give you a little bit of an overview of the model that we ended up developing, it did take us quite some time. The IHA model of development was to start, instead of coming up with a perfect model and then launching and opening your doors, we started with an idea of a model, and we worked with one family, tested that out, then took learnings from that, expanded it to 5 families, and we've been growing our program in that way. So it really is iterative in its nature, and we're constantly still learning and tweaking our model of care. So very, very different in terms of we didn't come with very set parameters about what this care delivery would look like, and I'm sure Veena could tell lots of stories about how she has gone over and above and around the system to try and learn what those barriers are, to then help us get to a place where we could actually streamline or remove some of those barriers. So it's been a really exciting piece of work, and a bit unconventional in its approach. And she's going to go through the real details, but just to point out that we do start out with patient identification. We have an algorithm that we've developed, and those kids are being identified both at Children's, Sunny Hill, and within mental health. The families are then provided with an opportunity. They're asked if they want to participate in the Connect for Care service model, to be connected with a single care coordinator. Veena will talk to you about how she works with them to create a shared plan of care, and how she works within the system, within our walls, as well as externally to all the other services that the child may benefit from, to help coordinate and to really ensure that the needs of that child and family are being met. The goal is really that through coaching and connecting, that we can be more anticipatory rather than reactive in our approach to supporting these children and family, and that in doing so we help mitigate a lot of the crisis that sometimes these families experience. I'm just not sure if I mentioned right at the start, but the population that we were working with and that we identified at the beginning was a population that had significant developmental behavioral complexity with some medical complexity as well. So that we honed in on that population to start with, and I'll pass it over to Veena.
Great. I'll actually go into sort of the algorithm a little bit more now. In terms of the C4C service model, as Rita noted, we worked on an identification algorithm to support a specific patient population who had multiple complex needs in 3 domains. You can't really see it there, so I'll kind of speak to it. One of the domains was medical condition. This could include a neurological, genetic, or a metabolic disorder. The other domain was a developmental condition, which could include autism, autism-like symptoms, intellectual disability, or a global developmental delay. And then the last domain was mental health condition, and this could include self-injurious behavior, aggression, severe anxiety, irritability, or psychosis, or pervasive hyperactivity. We used these 3 domains for quite some time, probably for about 1.5 years. However, in May of this year, we started a pilot which added a psychosocial domain. This was because the cases that were coming forward all had some layer of psychosocial concern, which exacerbated the child and family experience as well. This was taken into account to reflect the increased complexity of these patients, and at the same time, it allowed for the ability to work with children who maybe had 2 or 3 medical health issues, but whose complexity was increased due to a specific psychosocial concern. The psychosocial domain includes concerns such as parental mental health, low socioeconomic status, geographic isolation, cultural isolation, examples of ESL, new immigrants or refugees, and also caregiving needs for more than one child with special needs. It's helpful to maybe look at an example of a patient who maybe only meets two of the medical domains, but also meets the psychosocial domain may look like this. For example, a child who's diagnosed with autism has significant mental health concerns with self-injurious and aggressive behavior. And the psychosocial challenges include geographic isolation. For example, the family lives in rural BC with limited services and supports. They're new immigrants with language barriers and are low income. So supporting a child with special needs within this family and environmental context highlights the importance of the social determinants of health, targets more than just the diagnostic needs and the medical interventions, but the environmental factors that require support to best meet the needs of the patient. The algorithm also includes severity factors, which is helpful in determining the priority of need for the patient family. Some of these factors include the child's severe impact on daily functioning, restricted participation in school or daycare, unable to participate in the community, and multiple emergency visits. The referring clinician also needs to highlight what the service need is, and this sometimes can just be one specific thing. Coordination between multiple clinics is lacking, or the family has been able to not access services in the community. And so all of these things sort of highlight the significant needs for the family and where the care coordinator needs to start. Oh, how do I go to the next one? So at this time, referrals are only accepted within BC Children's and Sunny Hill with the involved programs because we're still learning and building the service, as Rita said. Originally, we did do a trial of community referrals from community pediatricians, but at that time, we didn't have much traction, and that could just be because the pilot was just in its first steps. It's definitely still something that we're considering in the future, especially now that the service is up and running. Referrals can come from anyone who's working in a capacity with a patient family. So that can be a physician, a psychiatrist, developmental pediatrician, or an allied health professional, social worker, clinic, nurse clinician, or a case manager. And we just want the person who's referring the patient to be able to speak to their needs and complexity. And it's also an expectation that the referring clinician be available for consultation or shared care planning as needed. In the hopes of increasing capacity for the service, given currently there's only one care coordinator, who's me, we also have piloted intervention levels, which are assigned at the point when the referral is accepted. And so, as you can see there, we've got the consultation only, which is sort of short-term, 1 to 4 months. That's not set in stone. The consultation only basically can serve many purposes. Some examples of kids referred in with this involvement means that, they could just be getting support on a specific resource in their community or helping with accessing a certain service in their community that might have been difficult to access before. It could be that the care coordinator just provides professional consultation to a colleague who is working with the family, specifically on resources or even streamlining an assessment. But the goal of this is that it's much more specific so that we can take in a few more patients on the caseload. With, of course, the care coordination, the extended involvement, this is the original framework of the Connect for Care service, which most of the kids still come in as. This really provides continuous involvement with a wraparound approach for the patient and family, and this includes collaboration with their medical and community providers. And like I said, the majority of kids coming through continue to have the extended involvement and the wraparound approach. So let's move on to discussing the work that starts when we connect with a patient family. Prior to the intake over the phone, the care coordinator completes a full chart review, and this can take some time because part of the role of the care coordinator is to do as much work as possible ahead of talking to the family, learning about what's going on currently, understanding the history of the child, so that when they speak to the family is not in the position to have to repeat themselves over and over again. Parents really appreciate this. When the intake is being done, the coordinator will check with the family to see if there's any updates and see if there's any corrections in terms of the information that they have. And then it gives the parents or guardians the opportunity to provide any additional details or updates. The intake is very open-ended and in this way very family-centered, as the parents and caregivers are asked about their perspective of needs and issues in terms of what they would like support with. With this information, the care coordinator helps to support a goal planning approach with the family's specified needs and works towards meeting the needs in a prioritized fashion with the agreement of the parents and caregivers. Further to this, which would be the next phase of work for Connect for Care, is working towards the care planning document. We've already started a bit of this, but it needs to sort of move forward at this point in time. This care planning document sort of would be a living document that we would note down the goals, and of course, as the needs change with time, the team members and the family would be apprised of this. I'll take some time now to talk about the specifics that the Connect for Care service provides for patient families. This list is absolutely not exhaustive. Coordination of multiple appointments, especially important for families who live out of town. Quick example, if you've got a family living in rural BC and they're coming to BC Children's and they have 5 clinics involved with their child. We were having families who were coming down for a neurology appointment, heading back home, had a voicemail that they had a biochem appointment. They were back down 2 weeks later, and so on and so on. This is exhausting for families. It takes up a large amount of time with accommodations, with travel and expense, time away from school and work. So part of the role of the care coordinator is to work with those clinics, try to see if we can get those appointments within a small amount of time, and so the families are coming down for fewer visits and getting a lot more work done during the times that they're here. Coordination of communication between clinicians and physicians to offer a more cohesive plan of care. This is super important. Like Rita was saying, sometimes one clinic will have recommendations and another clinic will have another recommendations that are not congruent. And so part of the care coordinator's work is sharing information between clinics, helping those doctors have an avenue to speak together. There's been examples where we have infant psychiatry with the autism team here working together. And that way, everybody's on the same page and working alongside with the family with the same information. The other piece of work is streamlining assessment pathways and coordination with program areas to think out of the box to support complex patients. Obviously, every clinic has their own eligibility criteria and their pathway, and we know for some of these complex kids that those boxes of pathways don't always work. So part of, I think, the novel idea of Connect for Care is working with program managers to say, is there a different way we can do this for a family? And we've been very, very successful in creating new pathways for this, small population of kids to make assessments more efficient and streamlined across clinics. The care coordinator can support school planning, can be involved in IEP planning, advocate with regards to the Ministry of Education, special needs designations. This is also really important. When we've done our diagnostic assessments, the families are out to the community, and one of the largest places where support's going to happen is at school, and many times the information that's been done through the diagnostic assessments is not translated to the schools. And there's a couple of different things that are happening there. Sometimes the schools don't actually even get the documents. There is some information lost in translation. Having a care coordinator as a point person and with the consent of the family, the care coordinator can share some of the medical information. Also, the reports are often very, very lengthy, so the care coordinator can act as a point person in terms of providing take-home messages to the school so that they can understand maybe the complexity of the child. At the same time, sometimes families aren't equipped to advocate for their child's needs in the school, so the care coordinator can act as an advocate as they understand what the criteria are for the designations in the school system. The care coordinator is also able to collaborate with the Ministry of Children and Families, Children and Youth with Special Needs, which in BC are sort of the main funding sources in the community for kids with special needs. And again, many times it's about just highlighting the needs and the prioritization of support services in the community that is what a family needs. When they're already dealing with so much, having another person as an ally to help support that conversation with some of those service providers can be very, very helpful. And really the last thing, which I think is really important, is the coordination of community integrated service meetings, which brings together the parent and the caregiver and several of their service providers. there generally isn't time or the mandate in specific clinics to bring together large meetings that include many service providers. This could include up to 5 or 6 service providers: school, nursing support, MCFD, CYSN, child and youth mental health. But C4C is able to do that for this complex population. And in these meetings, we work on specific action items, which helps to support accountability across the board and also helps to reduce any duplication of work. It also reminds everyone around the table that each provider has a piece of responsibility to take on, and this really supports a shared approach to care. In terms of ongoing support, patients who are enrolled in the Connect for Care service will continue to have support over the years when needs arise. This framework supports the premise that needs arise at different times across the developmental trajectory, and we want to be preventative so that we're decreasing crisis. We want to be able to plan for the right assessments at the right time. Long-term involvement also enhances relationship building, which supports the care coordinator's ability to coach parents and guardians, increasing their own capacity with navigating accessing services, advocating for their family, and networking within their own local communities. And this has been a really positive piece of the work. It's been really nice to see families who have started off feeling very overwhelmed to have been working with them over a year, and seeing them reach out to parent support groups, facilitating their own meetings now with the schools. The capacity building is a really, really great component of the Connect for Care service.
So lastly, our work doesn't stop with Connect for Care. We are constantly looking how we can leverage and expand the service. We anticipate that on a yearly basis, we have about 100 kids that might fit this model and would receive support through this service. Right now, given that we only have an N of 1 from our funding structure, we are somewhat limited into how many kids we can take on. So we are always looking at how we can expand that, how we can maybe shift and start to leverage other avenues and resources to expand this really important support. I think we've proven that it does make a difference for these families. The feedback that we're getting from the families has been really positive, and has made significant difference to many of these kids in terms of the length of time that it took for them to achieve a diagnosis, to start intervention, to having those supports set up within the community that they're able to be more successful. We have a lot of interest across our organization in our approach and in the model, and in fact are starting to look at both how we marry the methodology that we've used and the learnings that we've had from Connect for Care to other really high needs populations that we see at Children's Hospital. So we're just starting a group that's now going to be looking at the CAFC guidelines for children with complex medical needs, and so we're excited to start that work as well. I think that's it for us right now in terms of what we were going to present, but we're happy to take on questions or comments or.
Yeah, thanks so much, Rita and Veena. That's awesome. I've heard some of this before, but you learn something new every time. Anybody, Amanda, Deb, any comments or questions from your perspective?
2 seconds. It's Deb. I thought it was great. It's interesting to hear what other people are doing, because the challenge is always developing the partnerships and trying to make things more seamless for families, because we run into the same challenges here.
And yes, it's Amanda. I agree. It's great work, and it's much needed work, right, in terms of the transitions and that work done there. So yeah, good job.
So it's Lisa. I'm just wondering, you have funding for your N of 1 to do all of this. Is that sort of set in stone funding, or do you have to reapply for that every year, or is it just part of your budget? Like, are you safe?
Are we safe?
That's Leslie. I'm gonna let her respond to that.
The funding is it's agreed to be permanent funding or a position, but it is currently an unfunded variance, so it's a technical thing there. I think that as we move forward, it's pretty undetermined right now what that will look like to grow the service, and I think that's part of the education of other services is that these kids are not new to us, right? So we have to protect. We're in this kind of odd position where we're protecting the service from becoming overwhelmed, because then it becomes dysfunctional, and that's a pattern that we see all the time, right? You set up a new service, it's great for 6 months to a year, and then it's flooded. So we've been in the privileged position of being able to keep those thresholds closed, and to gatekeep and be specific about who we're taking on by keeping it internal, and then we need to start to look at how to grow it. And the likelihood is that that will be without additional funding. So if we look at that as the reality, how are we going to then build some exchange with these other programs? These kids are known to all of us. They're already in the system. So how can we look at working differently, which may mean hopefully that we can work on a partnership where they will give us some FTE rather than funding. So we'll have to look at how that works out. But that it's a hard sell, that piece of it.
Yeah, what we found especially when we were first looking and doing the design, and the conversations that we had when we talked to staff, is they could pick out these kids.
Yeah.
They were not, they were the kids that, one of our intake people said they came with a red flashing light. They knew that this was the kid that they were going to be spending a significant amount of time on. Yeah. So these kids are touching our system over and over.
Oh. Hello? 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 Are you there, Rita? Amanda, are you still online?
I'm still online, yes.
Yeah. Okay, I think that they just became disconnected. Looks like they're trying to reconnect.
Okay.
So just give it a second and see what happens.
Okay, sounds good. maybe some technology problems there.
Yeah, sounds like it. Seems like it. Well, that's kind of unfortunate.
Yeah, no, it's a really good good presentation and good question about the funding.
Mm-hmm. Did you have any other questions? And I mean, I can forward them to Rita and Veena.
No, I don't think so at that time. I think that funding was a good question, right? It's just about sustaining the work and.
Yeah.
All right. If I think of anything, I'll give you. I'll send an email.
Sure, and I'm going to post the presentation, and if you want to share it with any of your colleagues, that's great. So.
Oh, perfectly. Certainly I will. Sandra wasn't able to attend today, but I'll certainly forward it along to her as well. And if there's any questions that come up, then I'll connect back with you then, Lisa.
Oh, it looks like maybe they've come back online.
Okay. We're back, and you missed her really brilliant, long-winded answer. Talking to ourselves. We didn't realize until I turned around and looked at the screen that somehow we'd been disconnected. But we have no idea what you heard or not.
Okay, where were you when? Well, you were in the middle of the funding question, but it was, yeah.
Had Leslie finished talking, or was I talking?
Yeah, Leslie had finished talking, I think.
Okay, well then that's good. That's the most important. I think the only thing I was adding was that it's these kids are in our system. We do provide services to them in multiple different clinics and in the community, and it's sometimes it's really hard to tangibly see. So from an operational perspective, we want to say, are we making a difference financially? Is there some savings that we can then redistribute to create another position? And it's hard to see that when the savings are across the board, across sectors as well. So we have been partnering a little bit with a program out of Calgary that is doing some similar work to us, but narrowed into the population of kids with autism. And they have just launched some work with the University of Calgary and a health economist to look at how they can capture some of the economic impact that having somebody support the care for some of these really complex kids has in the long run, to help us perhaps as organizations to move to more of a proactive, preventative type of approach.
Yeah, it's interesting because all these different sectors as well, they have their own budgets, they have their own formulas for things, they have their own, and yeah, not always willing to or able to share. I shouldn't say willing, able to share things. So.
Yeah, well, yeah, it's even hard within our own organization amongst programs and amongst clinics.
Yeah. Well, another layer of complexity.
Yeah, so it's almost like as organizations we need to adopt a belief or value that particularly that there is a subsection of the population that requires a different way of receiving care, that we know that we're going to need to upfront do some funding around that, and that over time we will see savings across the board, that we need to invest at the start.
Yeah, and just to take it from the other side too, it's kind of tough when you have to put that return on investment around care for people, but it's the reality.
We know it's the right thing to do.
Yeah.
We know from families that this works.
Yeah.
And it's hard that we're caught in this kind of
because you can't show it on paper
paradigm
very easily.
Yeah.
It's been one of our biggest struggles is to try and show our outcomes. So we measure outcomes in terms of experience, health outcomes, as well as we've been trying to measure cost. and
Yeah,
the cost one is.
yeah, the whole triple aim piece.
Yeah, exactly.
All right. Well, Amanda and I were talking while you were talking somewhere else. And so I don't know that we have any more questions at this time, but thank you so much. This was awesome. Do you have any final thoughts or words for us of wisdom? And Deb had to leave, and we will be sharing this presentation with the rest of the folks who weren't able to join us today. So
I think the good thing about this service process of this services development is that it has a really strong foundation in the methodology, and the project piece of it was quite long term before the service started. So it's kind of an odd way around to do things, or unusual, not odd, but the
yeah, no, it has a strong foundation. Yeah, like you said, the methodology is very sound.
Yeah, whereas most services really are set up by throwing a bunch of money at something and see what happens.
Yeah.
We don't live in that reality much anymore.
Well, I don't think anybody does, but sometimes we just don't know what else to do. So,
Yeah.
but this is it's yeah. I mean, the IHI and CFHI, they always have these strong foundational sort of frameworks that we can learn from and adapt, right? So, anyways, it's a great great final thought for us, and thank you all, Leslie, Rita, and Veena. Yeah. And we'll talk to you soon.
Take
Thank
care.
you.
Bye-bye.
Okay, bye-bye.
Bye.